the head of medical standards and integrity at the RFL. I'm the head of medical standards and integrity at the RFL as of Christmas, January, just gone. Previously involved with match officials, the community game, and the compliance team across 13 years at the RFL. I'd just like to say that we're incredibly grateful to welcome you to this evening session, and the individuals who will lead the session. We were offered a fantastic opportunity by Professor Willie Stewart and Craig Ritchie to provide this session. They did a similar seminar with the Rugby Union Players Equivalent, and we were linked up via Kevin Sinfield, which we are very grateful for. The calibre of tonight's speakers is second to none, internationally renowned and respected for the work that they do. And we hope that the session will offer reassurance, insight, and the ability to go forward from here and be potentially proactive with your brain health.
Thank you, Laura. Just want to welcome everybody, really. I got introduced to Willie over Christmas on the back of the Rodborough MND fundraising we were a part of, and Willie's been a great help and supporter in all of Rob's challenges. But I got introduced to him and instantly struck a chord with him. He wants to make sport safer, and he wants to look after current players and past players, and I hope there's a great mix on here today. Unfortunately, I haven't met Craig face to face. I've been on a couple of webinars where both Craig and Willie have presented, and I just felt, having sat on them, that I needed to give everybody in our sport an opportunity to listen, because there's so much scaremongering out there, and there's so much bad press about concussion and the negativity around playing contact sport, that I felt that our sport needed to be aware and understand, just like rugby union and soccer and other contact sports, needed to understand, and I'd like to say put your minds at rest a little bit, and I'm hoping Willie and Craig will provide some of that detail tonight. So thanks everybody for joining. Like I said, the big driver in this is to help make rugby league safer and to support all our former players and current players. So again, I'll thank you both. I think Rugby League Cares and the RFL have fully bought into this. They're working as hard as they can in making our game safer as well, and they're absolutely aware of how important it is to look after those who have left the game and who are past players. So without further ado, I'll kindly pass on to Willie. Thank you.
Let me kind of, if you like, start by just giving you the kind of this sort of rapid 2 or 3 slides of introduction. Craig and I made a promise we weren't going to put slides into this, but actually, while he was talking, I just threw some slides together.
I'll pull some slides together too if you're going to be like that.
No. So essentially, the reason that we're here is because there's been this recent attention on concussion. The reason that there's a lot of recent attention on concussion is because of concerns about a link later in life with dementia. There are obviously immediate problems with concussion, which we can come to, but the real reason that people have started to worry about it a lot recently is this link to dementia and dementia-like syndromes, degenerative brain diseases, to put them all together. And although this is a recent attention, it's been around for a long time. And in fact, the first link was way back in 1928 when a pathologist working in New York made some observations on former boxers that they seem to have sort of shuffling gait, some problems with speech, some confusion and memory problems that he called punch-drunk syndrome. And that's a picture you can maybe conjure up in your mind of boxers from a bygone era with that kind of slurred speech and slightly slow. And he reckoned this was more than just some knocks in the head. This was a degenerative brain disease, which he called punch-drunk syndrome. It was gone through a few name changes over the years. For a while, we called it dementia pugilistica, but just a fancy way of saying boxer's dementia. And probably because we called it boxers' dementia, we made the mistake of thinking it was only a problem with boxers. But in the last 20 years or so, we've recognised that actually we can see it in other places as well. It's nothing to do necessarily with being a boxer. It's to do with exposure to repetitive head impacts and head injury. And so we now call it this thing, which is actually very hard to say, chronic traumatic encephalopathy, CTE for short, which is very easy to say. So we'll just call it that. And in that we thought we could see it, we're seeing it more to do with brain injury than necessarily with being a boxer. I kind of predicted foolishly about 10, 11 years ago that it would only matter of time before we started to see it in places such as our more familiar sports, rugby and in football. And within a year or two of saying that, a friend of mine in Ireland called me up and said, get yourself over here and have a look at this brain that I've seen. I think it's this CTE in a rugby player. And so I went across, and sure enough, sadly, this was a case of CTE in a rugby player. And the first described, this was an Irish rugby player, Irish in nationality, although he never played for the senior team, but he was from an amateur era of rugby union. And we've done some wider work looking at this is the work that gets most attention at the moment, which is to do with the footballers, the soccer players. And then there we've reported from a large population of Scottish footballers that there is a risk of about 3.5 times higher chance of dying from degenerative brain disease, this mixture of different diseases. And within those different diseases, the risk changes. So risk of Parkinson's disease, which is one of these degenerative diseases, is about double what we'd expect to see in the population. Motor neuron disease is 4 times higher than we'd expect to see. And Alzheimer's disease 5 times higher than we'd expect to see. And importantly, when we look at the brains of rugby players and footballers with dementia, we see this pathology, this CTE pathology in their brains. And that's kind of telling us that something important in this around about brain injury or head impact exposure is perhaps the risk that is leading to the high numbers of degenerative disease in former footballers and rugby players. And so this is kind of where Craig and I are currently thinking about this, is that actually if it is this brain injury thing, if it's head impacts in sport, if it's tackles in rugby, if it's heading in football, then actually there should be a very simple way of preventing it by trying to cut down on head impacts and get better at recognising head injury. So in people playing the game at the moment in their kind of 20s and younger, just cutting back on head impacts could be important. Rugby, cut back on training. You don't have to change the game much, but you can cut back on training. We need to get better at recognising the guys and the women who've got dementias in later life. But as Craig and I will no doubt discuss with you, that we really don't have good treatments for that age. Once somebody develops dementia, degenerative brain disease, we really don't have anything to change the course of disease. We can support people and we can make the diagnosis and we can assist with them, but we can't change the course of the disease. In this bit in the middle, where I guess most of us are on this call tonight, this bit between leaving the game and developing a disease or developing a syndrome, if that's where you're going to go, this bit in the middle is where we might be able to make a difference. It's where people are maybe anxious about the future, but actually there's something we might be able to do to change the course of disease. There are things that we can do to improve our brain health, our prospects for future in brain, which we might be able to address. And that's what Craig and I are keen to discuss with people at the moment, is not to just assume that because of injury collected playing a game of rugby or playing a sport, that you have to wait for the inevitable outcomes. The outcomes are by no means inevitable, but certainly the things we might be able to do to change the course of disease. And this is where this thing comes together. This is what Craig and I are currently working on, which is this the umbrella we've got is brain hope, because we're trying to give people hope. Actually, it's not despair, there's hope. And this links up research that Craig and I are involved in, but also education. This evening, sitting in a seminar, chatting to guys like yourself and answering as many questions as we can, and support, because we recognise that's required. So that's through rugby players associations, it's through clinics which can be set up to look after people and guide them, and so that's where we are. So this is the model that we're trying to create, not one of despair, but one of hope, and trying to find ways of maximising brain health and prolonging brain health as long as possible. Just let me talk. Craig mentioned that we got a rugby study up and running. It's carefully titled Rugby Football Cohort. It's with an eye to rugby union, but to be quite honest, neither Craig and I are particularly we're not so blinkered that actually rugby league would be excluded from study. What we're looking for is people who've participated at reasonably high level in contact sport, and this one just happens to be funded to look at rugby. And what we'll do is we'll look at our former players alongside this excellent cohort of individuals that Craig has been studying for some years, Craig and colleagues, and that's people who are aged between 40 and 59, who all sorts of fancy tests have been done to try and understand what a normal aging brain in that age range looks like, to try and get an idea of what early stage of dementia or early stages of degenerative brain disease might look like, and again with a view to changing the course of disease. So we'll look at rugby players alongside that. Last year we got the study rolling just before COVID with this chap Shane Williams, who you may know plays the other former rugby, and he was our first rugby player in the study, and then we had to shut down because of COVID. So really in the last few weeks we've just got going with an aim to recruit 50 rugby players, and I'm delighted to say that as of today I think we've got just under 10 rugby players, which is fantastic. We haven't even started properly trying to recruit. And again, this is all about trying to figure out what's happening with a view to actually providing ways of changing it, stopping disease happening before it starts. So that's just a brief introductory run of slides, which I said we weren't going to do, but I just did.
Thank you, Willie. That was excellent. I think to sort of kick some questions off, Laura kindly gathered some from some past players, and I think if it's all right with you, I'll pose these to both yourself and Craig, and then sort of see if we can get any more from people who are part of the webinar, and hopefully it's got people thinking a little bit. I think the obvious question is, how do we know when something's wrong? Because like most other rugby players, I'm forever forgetting people's names and losing my keys. What does that mean? When should we start going seeing a GP? When should we start seeing a doctor? Look, I would say at this point, I've always forgotten people's names, so it's not new to me. But can you give us a steer on that?
Do you want me to pick that one up, Willie?
Yeah, okay, go ahead.
I mean, I think one of the probably the most challenging things in this field of medicine is that despite a lot of hard effort, we don't have single tests or even groups of tests that confirm a diagnosis. So, for instance, if you took heart disease or cancer or lung disease, it's highly likely if you went to a doctor, they could do a range of tests and they could confirm one way or the other what it is or what it isn't, more specifically. We're not at that point yet with neurodegenerative disease. I often say it's because, unlike other branches of medicine, we can't do a biopsy. We can't do a brain biopsy to see what's actually happening in an individual's brain. So what we have to do is look at the symptoms they have, the risk factors that they may have, and complement that with things like brain scanning and maybe blood tests and spinal fluid if it comes to it. The problem is, of course, that some of the symptoms of early Alzheimer's disease are normal day-to-day, things that happen to all of us. We're all capable of, from any age, of forgetting something or finding it hard to remember somebody's name, etc. And I think the problem is that it depends really on your own sort of perception of risk as to whether or not you think that's important. So, for instance, if you're in your 70s or your 80s and you've got a strong family history of dementia, that forgetfulness is going to mean a lot more to you than it would to a 40-year-old who's got no family history. And that's just because you perceive your risk to be higher of having, for instance, Alzheimer's disease. And I think one of the problems has been over recent years is because of the media attention around, rugby and football, that when we speak to, and Willie does this a lot more than I do, and has been doing a lot longer than I have, when we speak to rugby players and football players, they're terrified because they believe that, as you said, Kevin, forgetting your keys is an early symptom of something, that's inevitable in the future. So I know that's not a really great answer, because it's actually 9 times out of 10, it's probably not going to be anything to do with any brain disease. Well, probably 99 times out of 100, to be honest. And the other key issue, and this is where I think the GP or in the near future the brain health clinics will help, is there's other reasons that people may be forgetful. And the number one reason that I often see in clinic of, dare I say, younger people who've got memory problems is actually mood problems. It's anxiety, it's stress, it's depression. When you're depressed or you're anxious or you're stressed, your brain isn't able to focus and concentrate as much as it can do if you're not anxious or you're not stressed. So if you can't focus and you can't pay attention to something going on around about you, it's therefore impossible to remember it a few minutes later. Okay? That's not a brain disease. That's like I say, stress, anxiety, depression. And I think having that reassurance or having that management of that other condition, which is 100% treatable, is critically important. So I think it's the salience, it's the importance that people attach to normal everyday occurrences like forgetting things. There's where I think reassurance from speaking to a doctor, speaking to an expert, having maybe some further tests on excluding things like neurodegenerative disease can provide a lot of reassurance and therein hope. So Willie, I'm not sure if you want to say any more.
Yeah, fully echo that. And I mean, one of the, Craig does a lot of the kind of face-to-face, chatting to patients or prospective patients and doing brain function tests. But I reflect, we had a meeting earlier today. It was a research group meeting which went on today, and we were talking about how we might extend research, not just in a rugby and footballers, but also just in general, trying to understand how brains age and develop. And one of the guys on the call, we're talking about possibly enrolling younger people. So at the moment we're looking at people aged 40 to 59, and the question was, what about bringing in younger people and getting an idea of how young brains are changing, and whether we can even begin to pick up earlier signs of problems in people in their 20s even. And one of the really important comments there was that, well, actually a lot of the brain function tests that we currently apply in the 40 to 59-year-olds are just too easy, too straightforward, and we need to come up with something more sophisticated for the young people, because just the reality is that as we get older, our brains do slow down slightly, and that many of these tests are kind of age-dependent assessments. So, the older you are, it's expected your performance won't be quite as good as a 20-year-old. And that's kind of reflected in just our normal life as well. I don't feel my brain's functioning quite as well as it was when I was 20. And that doesn't say much for how my brain was functioning when I was 20. But that's natural. But the problem is if and I guess this is what our worry is, if you're in a population that's being told day in, day out virtually that you're at very high risk of dementia and normal aging's there in the background, then you begin to worry. As you say, Kev, you lose your keys and you begin to worry. It's more than just part of normal life.
I think there's just something that you said as well, Kevin, I want to pick up on. You said you'd always been like that. I think that's a really important thing to pick up on, that neurodegenerative disease, degeneration means shrinkage and change. So people have different strengths and weaknesses, and that applies to all aspects of life, including cognition and thinking. And some people are very good at finding directions, and some people are very good at remembering lists, and that's just a skill they have. If it changes, then that's more important, that's more relevant. If things seem to be changing quite observably, then that's usually a problem. The other sort of key observation in some ways is it's often other people around you who observe the changes rather than yourself. We've got a phrase we use in clinic called the head turning sign. And that is when you're interviewing a person who's got some cognitive problems, and you ask them, how did you get here this morning? And they're sitting there with their spouse, they very often turn and go, how did we get here again? And that's the head turning sign, because they're referring to people in the room who may remember for them. And also the other thing is that memory clinic referrals that I get, if it's a person who's referred themselves to the memory clinic, who's observed a problem with their own memory, I often think it's more likely to be something other than dementia. It's when the family bring them up and say, look, he's just not the same as he was. He's changing. That's again really quite a powerful indicator. It's probably something to do with their brain health and dementia. And that's certainly how it applies in older people, and I'm sure it'll be the same in younger people too. So it's observing it yourself is probably lower risk, and referring to other people for assistance is a good sign as well.
I'm just going to underline that. I unfortunately, part of the work I do is that, as you probably appreciate, I examine the brains of people who've passed away with dementia and who may have been involved in sport as part of our research activity, but also as part of a diagnostic service that we provide. And part of my workup in those cases is at the end of reviewing the case. I'll sit with the family for as long as it takes and listen to the story of how their disease developed and what the course of the disease was. And actually, just Craig's reminded me, just on reflection on that, I can't think of any case that I've looked after in the last 5 years or more where, when I say, how did it all begin, the family say, well, he came to me and said, I think my memory's poor. It nearly always has begun with the family noting something wrong with the person that we're discussing, and encouraging them to go and get help. And in fact, there's often a denial from the patient, the player, that there's any problem at all. It's the family that really noticed something. So that I think that kind of reinforces what you're saying, Craig.
Yeah. Okay. Next question then. I think it's fair to say, having listened to you both, that age is probably the biggest factor in neurodegenerative diseases. For everybody who's been a rugby player and who has had some sort of head collision during the time, where would you sit concussion? And just for everybody listening, what are some of the other factors that contribute also?
So I'll do the head injury one because part
you do head injury, I'll do the rest.
Thanks very much. Because part of my shocking memory is I can never remember all the other ones, and it's Craig's party trick, he can remember them all. So there was a recent very, very useful article written in the Lancet, which looked at all the recognised modifiable risk factors for dementia. So these ones that we can influence. We can't influence. Unfortunately, we're getting older. Nothing we can do about it. Genetics we've been handed. Nothing we can do about them. But other things we're in control of. And they summarised these, and there's 12 of them. And in among them was brain injury. So having a history of exposure to a brain injury is reckoned by these researchers to contribute to around about 3% of dementia in the population. So for every 100 people in the population with dementia, 3 of them are probably there because of a history of head injury. Now, of course, that differs by population, because when we look at our former footballers, for instance, their risk of dementia was several-fold higher than normal population. So actually, head injury in footballers is a much greater cause of head injury than in the wider population. But overall, it's about 3%. Now, there's a lot of discussion about how certain are we that brain injury causes dementia, and to demonstrate cause, to say a brain injury in your 20s causes dementia in your 60s and 70s is virtually impossible, because there's so many things happen in life between then. But what we can say is it's associated, very strongly associated, because we see it at higher risk in people with a history of head injury. Our and other research show that the greater your exposure to head injury, head impacts, not necessarily concussions, but just the head impacts that you might get day-to-day in training, the more exposure you have, the greater your risk. And the longer you play, the greater your risk. Things like that tell us it's something to do with the sport. And when we see the brains down the microscope, we see a change in the brain, which is really unique to people who've had a history of brain injury. So brain injury is really important. But, as I say, it's one of 12 recognised modifiable risk factors, meaning that there's another 11 things that each of us could be doing who've been exposed to brain injury. There's another 11 things that we're in control of, which might change our risk. And that's the important thing that Craig and I are trying to sort of work on, is how can we work with those other 11 things to change the risk. And now it's Craig's job to tell you what the other 11 things are.
This is my little memory test. So I'm not gonna rise to the bait, Willie. I'm gonna cover them in a. I mean, I think Kevin, you're absolutely right. I mean, the number one risk factor for dementia is age, over above everything else. There are very, very, very rare genetic causes of Alzheimer's disease that happen, very, very infrequently. Maybe 10 people in the whole of Scotland, for instance, have these rare genetic mutations. But the vast majority of people, age is the number one risk factor. And if I'm sitting in clinic with somebody who's maybe got some early memory problems, I have, sort of a list of things that I'll ask them in the history taking. Do you have a family history? Do you have parents who had dementia? Do you have aunts or uncles who had dementia? Do you have siblings who have dementia, any memory problems? And of course, if that's positive, then it's more likely that that person's symptoms might be due to neurodegenerative disease. I always ask about head injury, obviously, across the life course. I ask them about the past medical history. Do they have heart disease? Do they have diabetes? Have they ever had depression, or are they currently depressed? What do they do to keep themselves busy? Do they socialize a lot? Do they go out with friends and family? These are things that, again, you can see as risk factors. If you're socially isolated, we know that's a risk factor, but it's also a great therapy for people. If you're more socially active, if you're more involved in clubs, societies, whatever it might be, that actually protects your brain. I often say to people that the best way to get your brain to light up is actually just to have a good lever, is to be out with folk, and that just stimulates the brain, and that's probably protective in the longer run. So I think there's things you can say. What have you done in your life that might be a risk factor? As we said, heart disease, diabetes, depression, head injury. Can't change your parents, so family history is not modifiable. And then what can you do to maybe reduce the risks going forward? And that's where Willie mentions is, we've just been seeing some evidence earlier today from our study that people who haven't got full-blown diabetes but have got kind of pre-diabetes seem to be showing evidence of brain changes that may be the very earliest moments of Alzheimer's disease, for instance. So, why do people get diabetic? They eat the wrong foods, they're overweight. Again, there's family history. So if you can prevent diabetes, you're probably going to prevent dementia in some ways. Depression, people should look after their own mental health, being socially connected. If you have got concerns or worries about your mental health, speak to a GP. They may refer you for talking therapies. They may refer you they may prescribe some antidepressant medication. Heart disease is another biggie. The brain is very complicated, as Willie knows, but I also think it's really simple. If it's got a good blood flow and it's full of the right nutrients and it's got enough oxygen in it, then it's probably going to be quite healthy. So good blood flow is, if you've got a good heart, you'll have good blood flow to your brain. The right nutrients, we talk about something called the Mediterranean diet, which I'm not sure is on is listed there, but we can certainly send you the food types that seem to be good for brain health in what's called the Mediterranean diet. And have good oxygen levels, so don't smoke. And one of the final thing I'll talk about is sleep. There's really good evidence coming out that people who don't sleep so well are at higher risk of developing dementia in later life. Now, we don't know exact details of that. Probably if you're not getting at least 6 or 7 hours sleep a night, good sleep, then that's probably increasing your risk. So I think having a healthy diet, avoiding all the usual things about smoking and too much alcohol, and having a good sleep and staying socially active is critically important. Physical activity is tougher. We don't exactly know really well yet exactly what level of physical activity to go with, but certainly keeping your weight down and being physically active is also critically important.
Okay, great. Thank you. I know we've got a slide to finish with, which I think would be a great take home for everybody. But before I do, I've probably got 2 more questions. So we're having this webinar over neurodegenerative diseases. And I think what's been lost in some of this, in all the negativity around it, are some of the benefits that sport give you. Now, we will all understand the camaraderie, the teamships, the memories, some of the things that some of these guys have been able to achieve on the webinar tonight have been wonderful. But sort of, if we dig a little bit deeper, sort of to give some good news tonight as well, because I think you've already been really positive about the neurodegenerative and concussion stuff, but sort of some other things around cardiovascular disease, certain types of cancers. Are there any things we can throw out there that have been really important for people who play sport? And then the second part of the question is, how important is it to continue being active, to ensure that some of those deposits in a bank account, if you like, remain with interest and keep growing?
Right, that's a really good point. I mean, it's so easy in something like this to focus on the dementia, the degenerative brain disease, because that's kind of why we're here to talk. But actually, one of the reasons that we set the football study up the way we did was not just to look at dementia outcomes, but also to look at other health outcomes as well, because I recognise there's a balance. You know, it's not all bad. There's a lot of good as well. And if you look at that study, when we looked at dementia outcomes in our footballers, what we found is that the footballers were living a bit longer. So they're living a couple of years longer. So that's a bonus. The other thing is that when we actually dug into it in the data, that the risk of dying from cardiovascular disease was very much lower, about half. The risk of cancers like lung cancer, about 80% of what we'd expect normally. We looked at mental health outcomes, mental health outcomes. We found that there are about half common mental health disorders. That's depression, anxiety, alcoholism, addiction, things like that. So mental health's better, cardiovascular health's better, just general health was better. You know, great. Sport's fantastic. All these great benefits, but this standout real problem of dementia. Now, that's where I come at this, because I think if we could just fix the dementia problem, imagine, I mean, we've got this fantastic, miracle tablet. Just go out there and play sport, because it's going to, give you great health, great life, all around. But we haven't quite got that one yet. Physical activity is incredibly important. I've got a really good friend who works at university whose whole research drive is looking at physical activity and health, and he's got some fantastic data. You don't have to run 7 marathons in 7 days to be able to stay healthy. Just walking half an hour a day, cycling into work, as I try and do, is good for keeping you healthy. And he can show that level of just general, low-level physical activity on a regular basis actually produces considerable health benefits, and that cuts through to brain health benefits as well. So sport, physical activity, is wonderful in terms of keeping us healthy. Participation in high-level elite sport is great for lifelong health, because it reduces mortality overall, death overall, it reduces cardiovascular, reduces cancer. But we really need to figure out what the problem is here with the brains and what's happening to brains. And if we can solve that, as I say, we've got a fantastic solution.
I mean, I just think the other thing, and that, like I said at the beginning, I've only just been starting to have these conversations with rugby and football players. Willie's been having these conversations for a long time in his line of work and his interest. But one thing that really struck me, which will be obvious to many of you, but something I hadn't been really thought about as hard as maybe I should have done, was that the structure, the camaraderie, the training, the club environment around rugby and football teams, which you guys probably all entered when you were probably in your mid-teens to play at the level you did. But then as professionals, you retire from your career in your early 30s, which is very unusual in terms of, careers and occupations. And I reflect, Willie and I went to medical school probably at the age of 17 and 18 and became doctors, and we will be doctors till we're 65. And that kind of lifestyle and all that culture that we have and the ties that bind us to our colleagues and to our work are there until late life. For rugby players in particular, football players as well, it's that change in your early 30s from that structured environment and that camaraderie and that social connectivity, which I heard from some people almost changes overnight. Literally, you're at the game one day, you're training, what have you, you retire, and next weekend you're not involved in it anymore. Now, to echo what Willie said, playing elite sport has got great net benefits, but one does wonder, and these webinars are fantastic examples of it, of how do you transition out of the game or stay in the game but not continuing to play. So there's those net benefits you derive of the training, the diet, the exercise, the camaraderie can be maintained through midlife, because that's going to be really, really important too.
Brilliant. Look, I am conscious of time, and I'm conscious that someone on the floor may want to ask a question. I know we've got a slide to finish with, which will be a wonderful take home for all of us. But I've probably got one question to both of you. If we would like to be involved in the study, how do we get involved? And would you like us to get involved? Because I'm sure, I'd certainly throw my hand up and say, you can do what you need to on me if it makes our game safer. So I'm pretty sure there'd be a number of blokes on here who do exactly the same. So if there's a way of being involved, or Rugby League being involved, how would we do that?
So I'll maybe take that. So after this, I can circulate the website address, because clearly being involved in the study is 100% confidential. So I don't, people who come onto this study, no matter who they are, it's 100% confidential. So we've got a website where you can just, contact us at preventdementia.co.uk. And one of my colleagues here, Sarah Gregory, will give you a call. If you leave your details on the website, she'll give you a call. You need to be 40 to 59. That's one thing. So I'm not sure how many of that applies to you guys. And we're only recruiting into the Edinburgh Centre at the moment. We do have a centre in Dublin, Oxford, Cambridge and London. But at the moment for this study, we're only recruiting into Edinburgh. And we're perfectly happy for people, if they can travel up to Edinburgh for a day. They also have to come back, minimum of 3 days later for a brain scan. So there will be a travel up and down to Edinburgh for that. We can help with travel expenses. We've got some budget for that. But the thing to do is to get on the website, register your interest, and then my colleague Sarah will give you a call and tell you much more about the study than I've done this evening. And if you're still happy, she'll send you out an information sheet, and then we can get you booked in.
That's brilliant. Thank you very much. I will kindly pass you back on to Laura now, in case there are any further questions from the floor. I know there's a slide to finish with, which is a brilliant take home, but I just want to thank you both for Rugby League to be in this space and to offer this today as a webinar. I think it's a huge step forward for the sport, and it's great to be in the same arena as the footballers and the rugby union boys, because we all know what could be coming as we get older, and it's really important we look after each other. So can't thank you enough.
Yeah, thank you, Laura. Just thank you everybody for coming on the call tonight. I think certainly when you look at the names and the faces on the webinar tonight, it's just fantastic that we've got a real good cross-section of all the stakeholders at the club, not just current players or past players. We've got administrators and medical staff and everybody connected with the game, and I think that just emphasises how important our game is taking this subject. And we do really care about our current players and our past players and everybody connected with our sport. So a big thank you for that. Big thank you to Willie, Craig and Kev for your presentation. I thought it was really insightful and useful, and the information was fantastic. Big thanks to Francis from Rugby League Cares and Laura from the RFL for all the hard work actually organising this behind the scenes. I think everybody you'll get a chance to be involved in this and watch it in the future. It's so useful for our sports. We really do appreciate that. As Laura has just mentioned, we'll ensure that all the information is available on the RFL and the RL Cares website and the channels, and that will include the recording as well. And any questions, please get in touch. We're more than open for you to get in touch with it, myself or any of the Rugby League Cares staff. And I'm just looking at the brain health slide there now that Francis has put up, and we've got quite a few of those programs currently in place at our clubs as well. So a lot of our player welfare managers are running some of these programs with regards to awareness of brain health, and it's something that we've started rolling out with the clubs, which again, is going to be a big part of our sport. And that's if there's no other questions, again, thanks again for everybody taking part. And again, if you need anything,